Hi, I'm Dr. Vivek Kaul, and I'm a professor of medicine in the Division of Gastroenterology and Hepatology at the University of Rochester Medical Center in Rochester, New York. It's my great pleasure to collaborate once again with WebMD and Medscape this year. And this edition focuses on the top picks, which I thought would be appealing to our primary care colleagues. So this is the best of ACG for primary care. This edition will focus on three main areas, which is colorectal cancer screening, functional GI disease, and liver disease. So in the first section, I'll talk about a couple of papers referring to colorectal cancer screening and hemorrhoid therapy. This first paper refers to disparities in the rates of multi-target stool DNA test completion for colorectal cancer screening. This is an important study because colorectal cancer screening remains an important aspect of both primary care as well as GI practices, but still has several challenges as this study depicts, as well as the Nordic trial, which was recently published in the New England Journal, suggested as well. So this retrospective study over 15 months had about 800 patients, and nearly half of them had undergone screening before. The tests that were ordered are depicted on this pie chart, about 80% by primary care, and then a minority by other sectors, including resident clinics. The results of this study showed that 483 patients, nearly 61%, completed the multi-target stool DNA test, and the median time to completion was about 25 days. The factors that were positively impacting test completion was Asian race and prior history of colorectal cancer screening. However, some factors were negatively impacting the compliance with this test, and that included African American race and tests that were ordered out of resident clinics or from other outreach programs. So once again, this study highlights that whereas we do have excellent colonoscopy-based and non-colonoscopy-based screening options out there, compliance may be a challenge as well. And nearly 30% of adults in the US who are eligible for colorectal cancer screening may not present for that test for one reason or another. So this remains a challenge. Awareness of these difficulties is important, and every effort, both clinical and investigational level, needs to be made to move the needle in this space. Our second paper in the colon section refers to evaluating what fecal DNA and FIT tests really mean. So in this particular paper titled, What Do False Positive Stool Tests Really Mean? Data from the New Hampshire Colonoscopy Registry was evaluated. This is a 5-year time period, which includes about 549 DNA tests from stool and 410 FIT tests. And the goal here was to understand that when you have a positive DNA or FIT test, what are the findings at colonoscopy, and when you call it a false discovery. So if you look at this slide, there are three categories of what constitutes as positive colonoscopies after a positive stool test. So the Deep Sea study included any cancers, adenomas, advanced polyps. The task force recommendations were that any colonoscopy that generates an earlier interval for screening or surveillance is considered positive, such as finding of polyps. And then, of course, clinically significant group included both these categories, as well as those that had serrated polyps. The next slide here shows that the false discovery rate, which is the number of positive stool tests with a negative colonoscopy, that means a colonoscopy that does not have any of the criteria that I previously mentioned, as well as the positive predictive value of these stool tests. So when they looked at both the DNA and the FIT populations that underwent these tests, they found that the false discovery rate really dropped if you included all the three categories of positivity, including the clinically significant ones, including serrated adenomas. So the false discovery rate goes down and the positive predictive value goes up in both these populations. And that's important to note, that when we do these stool tests, it's not only the cancer patients that we are counting, but we're also counting those patients that have serrated adenomas and proximal hyperplastic polyps, or any other findings that would necessitate, by guideline, an earlier surveillance colonoscopy. So that's an important takeaway from this paper. And finally, in the colon section, an interesting paper. We all know that hemorrhoids are a very significant cause of morbidity, both in primary care practice as well as in the GI practice. And many interventions, both surgical and non-surgical, have been tried over the years. But here's a paper from a hemorrhoid specialty clinic or center, which is a one-of-a-kind center that focuses on a comprehensive approach to hemorrhoid management, and the safety and efficacy of hemorrhoid artery embolization was evaluated in this paper. So a cohort about 126 patients, and they underwent hemorrhoidal arterial embolization using polyvinyl alcohol or coils. The technical success rate in this population was 100%, which is quite commendable. You can see that the patients underwent these procedures on an outpatient basis with no serious adverse events and only minor post-treatment effects. The outcomes suggested that bleeding rates, quality of life scores, hemorrhoidal related pain, all were much lower at the 3-month mark compared to the baseline scores. So yet another option for our patients with significant hemorrhoid disease who are refractory to medical therapy and conservative measures. So this raises hope in both our practices at the primary care level as well as in the GI practices, and likely more data to come on these approaches in the future. In the next section, which is functional GI disease, another huge subset of patients in both primary care and GI practices, picked a couple of papers, one relating to dyspepsia and a novel approach to the management of dyspepsia, and another one on IBS. So as we all know, cognitive behavioral therapy and the utilization of virtual reality based algorithms and experiences has now come into play in the management of IBS and functional GI disease. So here's a paper that actually looks at the impact of virtual reality on the symptoms of functional dyspepsia. Now, just for a refresher, functional dyspepsia by Rome 4 criteria is diagnosed with patients with one or more of the following symptoms with the symptom frequency more than equal to twice per week. That's postprandial fullness, early satiety, epigastric pain, epigastric burning, and there should be no evidence of structural disease. And these criteria should be fulfilled at least for 3 months with a symptom onset for longer than 6 months. The investigators looked at the impact of virtual reality in this realm. So 37 patients with functional dyspepsia, with 27 in the treatment arm, 10 in the control arm. And essentially, the patients were given a virtual reality headset where they had an immersive audio-visual experience, and the control population had a headset with two-dimensional nature videos. 17 patients reported some non-serious adverse events such as headache and dizziness, and one patient from the experimental group actually withdrew because of migraines. The mean total patient assessment of GI disorders symptom severity index, which is shown on the left side, significantly decreased in the VR group, which is the virtual reality group, and the total Nepean dyspepsia index actually improved in the VR group as well as in the control group. But only the virtual reality group had significant improvements in abdominal pain compared to some of the other criteria. So what the study tells us is that there may be something here in terms of managing our patients with functional dyspepsia, functional pain, over and above the lifestyle and medical therapy options that virtual reality may have a role to play, if not in everybody, but in a subset of patients going forward. So expect to see more data in this realm going forward as well. And last but not the least, in our liver section, I picked a study that reflects nearly 3 decades of data assessing the burden of obesity and specifically non-alcoholic fatty liver disease, which now has assumed global epidemic proportions. So the global landscape of non-alcoholic fatty liver disease results from the Global Burden of Disease study. This is data collected from the Global Health Data Exchange results tool. Global prevalence of NAFLD has increased by more than 50% over this time period. The mortality attributed to this disease state has increased from 93,000 to 169,000, and the disability adjusted life years increased from 2.7 million years to 4.4 million years. Now, the highest prevalence of this condition is in the North African and Middle Eastern regions. This is a problem that plagues, as I said, the Western world as well as other parts of the world. It's a global epidemic at this point with a worldwide prevalence of 32%. And not only does it portend negative prognostic implications from a chronic liver disease standpoint, but also from a metabolic standpoint as well, and has major implications for cardiovascular disease and such. So this is an area that is receiving a lot of attention, both in medicine at all levels, in GI, in cardiology, in metabolic health, endocrine, primary care, and lifestyle medicine. So this is going to continue to receive attention and focus going forward, and something that we should be concerned about as practitioners. So with that, I hope you enjoyed getting an update in these very specific areas of GI from a primary care perspective, and that you find this information useful in the care of your patients. Thank you very much, and I'll see you next time.